record it and then make it available. So I'm going to turn it over to Jason. He can give a brief introduction about himself, and yeah, we're here to answer questions. So with that thought in mind, you know, as you go about your days, if there is a pressing question, odds are your peers have the same question. So please let me know, and we'll be more than happy to reach out to our friends and see if we can set up a webinar or a meeting like this. So thank you guys for logging on again, and Jason, it's all you.
Okay, thank you, Laura. I appreciate everybody getting on today. I recognize a few names on the call. For those of you that don't know me, my name is Jason Belts. I'm a senior clinical consultant with OFMQ. I've been working for OFMQ and doing health IT work for over 10 years now. And so we do a lot of stuff around quality reporting, EHR incentive programs, ACOs, some of these other new terms you're hearing about. So really anything in the health IT realm, our team kind of helps out with. I talked to Laura a little bit. She was getting a lot of questions about MIPS, meaningful use, when to report, where to report. And so we thought it'd be a good idea to just get together and try to get all that information to you in one sitting. I will put the disclaimer that a lot of this stuff is very surface level. There's a lot of details on a lot of these programs. And so if you have specific questions after the presentation, we'll try to leave a little bit of time for questions, or you can always reach out to me or Laura and we'll help get those questions answered. So today, I'll start off talking about MIPS, which is the Merit-Based Incentive Payment System. That's for clinicians, so we'll talk about what they have to report, when and where they report. Then we'll talk about promoting interoperability for hospitals. That's kind of the new meaningful use, so we'll talk about the changes there. And then I'll talk about what you need to do for 2019 and moving forward and how the programs are going to kind of change and align. So starting off, just a little bit of overview about MIPS, where it came from. So you're probably familiar with the term MACRA. That's a big piece of legislation that came out a few years ago. And MACRA developed what was called the Quality Payment Program. Within the Quality Payment Program, there's two different ways that you can participate. One of them is participating in MIPS, and the other one is participating in advanced alternative payment models. And so below that shows you the 4 performance categories for MIPS. I think if you're in an APM, you probably already know about that and have a pretty good handle on it. So the majority of this stuff will kind of pertain to the MIPS side of reporting. So again, 2 different participation options. Within those alternative payment models, there are 2 different types. One are called advanced alternative payment models. So if you're in one of these advanced models, then you are completely exempt from having to do any type of MIPS reporting. There are some other different alternative payment models. They're not classified as advanced. If you participate in one of those options, it will get you some credit in different MIPS performance categories, but you're still going to have to report for the whole MIPS program. So this just quickly is a list of the advanced APMs in 2018. Some of the ones that you may be familiar with is the Shared Savings Program. Those are different ACO models. Also, the Comprehensive Primary Care Plus, CPC Plus, is another one that some people may participate in. So if you participate in any of these models or have a clinician that does, they're completely exempt from MIPS reporting. If they're just in a lesser model, like a track 1 ACO, not the 1+ or 2 or 3 tracks, then that will again get them credit for some of their performance categories, but not get them completely exempt from MIPS. So who's eligible for MIPS? Clinicians that are eligible for MIPS reporting include physicians, PAs, nurse practitioners, clinical nurse specialists, and then certified registered nurse anesthetists. If you're a little bit bigger organization and you employ dentists, podiatrists, optometrists, any different specialties like that, Medicare does consider those as physicians, and they're included in the MIPS eligibility determination. So you do, if you employ any of those specialty practitioners, you're going to want to check their eligibility as well. For MIPS, you have a couple of different participation options. Back under meaningful use, everybody had to report as an individual. There was no type of group reporting. Now under MIPS, you can report as a group as long as everyone in that group is within the same tax ID. So group reporting can be multi-specialty, but it's going to be everybody that's housed under a single TIN. Individual reporting is going to be single MPI tied to a single tax ID. So this is going to be for your individual docs or your smaller practices that maybe still want to report individually. And then newly introduced for 2018 was virtual groups. So for virtual groups, you can have 2 or more organizations as long as they are 10 or fewer clinicians that are eligible in those locations. But those different groups can come together and do group reporting as a virtual group. It just kind of gives you some of the benefits of the group reporting without having to actually be listed under the same tax ID. Some exemptions. So people who do not have to participate in MIPS, if you're a newly enrolled Medicare clinician, you're exempt until your year following your enrollment with Medicare. So you get kind of a 1-year grace period there. Below the low volume threshold, so they have a low volume threshold for claim payment amounts for the number of Medicare patients you see, and then there's actually a third identifier that is going to be added on as well. But if you do, or if an individual clinician does less than $90,000 a year in Medicare charges, or sees 200 or fewer Medicare patients, then they don't have to participate in MIPS. If you do fall below just one of those, but above the other, you can still choose to participate. So that kind of gives you a little bit of flexibility there as well. And then if you're significantly participating in one of those advanced alternative payment models. I just put this here because you may be participating in one of those advanced models, but have very few patients that you're seeing through that model. So some special cases like that, the provider might fall below the threshold and still have to report. FQHCs and RHCS, I know Laura mentioned we did have a question about this. So providers that are practicing exclusively in an FQHC or RHC are exempt from MIPS, and this is because of the unique way that they bill Medicare. You can voluntarily choose to report data under MIPS, but you don't get any of the incentives or penalties associated with it. You can check your eligibility on the website. So if you have a clinician that practices in an FQHC, but maybe they see patients in a clinic or at another site outside of the FQHC, for those providers, you might want to still check their eligibility on the website and just make sure that they haven't gone above that individual Part B threshold. So there are some instances where providers practice in multiple locations, but for the most part, if they're practicing in an FQHC or RHC, they're going to be exempt from MIPS reporting. This is the website. If you're not familiar with it, it's qpp.cms.gov. But this is a website. It's got a ton of information and education about the quality payment program. And you can also get on here and just type in an MPI number of a clinician, and it's going to tell you whether or not they're eligible to participate in the program. This site's going to show you a variety of data. So if they are eligible, you'll have a little message like this that pops up once you log into the site that will tell you the provider name and say that they're eligible for MIPS and they need to report. I have had instances where people may be logged in at the beginning of the year and checked and somebody was not eligible, and then they logged in at the end of the year and they were listed as eligible. This is because Medicare does two different eligibility review dates. So the first one that they complete is really looking at the previous year's claims data. And then they're going to complete a second review later in the year that's going to review claims data from September to the most recent August. So if you were uneligible in the first one, but then eligible with the second one, then that's what they're going to go by. So they're going to go by that most recent eligibility review. Once you're logged in and looking at your group or at providers, there's a variety of information that you can see. You can see all of the tax IDs and practices that a provider is associated with, and their eligibility at all those different locations. So again, it will also show you if they're eligible to report as an individual or as a group, and then if they fall into any of the special circumstance classes. Some of those special circumstances are going to be associated with small practices or practices that are located in rural areas. So if you are a small practice, CMS looks at that as practices with 15 or fewer clinicians. If you're a practice in a rural area or in a health professional shortage area, then you're going to get some additional flexibilities under the program. If you're not sure if you're in a health professional shortage area, this is the website where you can go and look that information up. I was on this recently for a grant, and I think all but maybe 2 or 3 counties across the state were listed as HPSAs. So there's a very good chance that your clinicians are located in one of those areas. So with the options for small practices, there's different bonus points that are added to the score just to kind of make up for some of the disadvantages that you might have with reporting or affordability of technology. They give you the option to form a virtual group, obviously, which we talked about, and then there's additional measures that may come in the quality category or some of the additional categories. This down here says ACI. I forgot to change that. That's an old name of the program, which we'll go over. That's now called PI, or Promoting Interoperability. But small practices also have the option to be exempt from that part of MIPS reporting if they choose. So we'll talk about that more when we get to that section. So with the MIPS program as a whole, now that we're done with eligibility, this is really the different performance categories within the program and how each category is weighted. So for 2018, you've got 4 categories: quality, which is worth 50 points. Cost, which is news this year, is going to be worth 10 points. Improvement activities is 15 points. And then promoting interoperability, which most of you are probably more familiar with as the meaningful use objectives, is going to be 25 points. So you have 100 points possible for your final MIPS score. Quality is going to be the category that looks at different healthcare processes, outcomes, and patient experience measures. Again, it's 50% of your final score for your 2018 reporting period. For quality, for clinicians, you have to report at least 6 measures, and one of those measures has to be an outcome or high priority measure. For quality, your reporting period is going to be all the 2018 calendar year. So quality and cost are both 12-month reporting periods. The other 2 categories, promoting interoperability and improvement activities, is just a 90-day reporting period. You can also get bonus points in the quality category. You actually get bonus points if you're a small or rural practice. You automatically get 5 bonus points there. But if you submit additional outcome or high priority measures, you can get bonus points. Or if you submit using electronic end-to-end reporting. So if you report directly through your EHR, if you report through a qualified registry or QCDR or the CMS web interface, you'll get bonus points for doing that as well. So really, claims reporting is the only way that you would not get those bonus points for reporting your quality data. For quality measures for clinicians, on the QPP, you can look at a overall list of the different quality measures that you can report on. There's 284 total measures, so hopefully you can find at least 6 out of those 284 that fit your practice. On the QPP website, you can filter all the measures. You can filter it by measure type, so the outcome or high priority measures that we talked about, that one is required, or by process or efficiency measures. You can also filter by specialty measure set. So you can just go to your specialty, whether it's family practice, OB, cardiology, and it's going to give you a list of measures that are really designed for that specialty. There is a little caveat that if you choose a specialty measure set that has less than 6 measures, that's all that you would have to report on. So say there's only 4 specialty measures and whatever that specialty is, that's all you have to report. For most of the specialties, there's going to be at least 6 or more, but there are a few random cases like that. And then you can also filter by your submission method. So if you maybe aren't ready to do that electronic reporting and you only want to see measures that are claims-based, or if you know that you're reporting through a registry, so you only want to look at the registry measures, you can kind of pick and choose of how you want to view those measures. Some examples of these quality measures, just to kind of put this more in perspective of what these measures are that you're reporting. An example of one is the diabetes measure. It's looking at hemoglobin A1C levels and whether or not they're in control in your patient. So everybody that has one greater than 9% is not going to be in control. And then hypertension, there's a controlling high blood pressure measure. So you can see there's just a number of different measures that are really looking at kind of the clinical side of things that you're measuring. The next one is going to be cost. Cost was removed for the first year of MIPS, and then it got added back for 2018. Cost is 10% of your final score for 2018. Cost is strictly claims-based reporting. So your reporting period is all year, but there's nothing you actually have to report. Medicare is just pulling all of that data from your claims. There's 2 measures that are in place this year. One of them is the Medicare spending per beneficiary. So what that measure looks at is your total cost surrounding a hospitalized patient. So it's going to look at the cost of care right before, then while they were in the hospital, and then 30 days prior to that hospital discharge. And so it's looking at the total cost of services there and then comparing that to other like cases. And then your other measure is your total per capita cost. So this is really looking at the total cost of primary care services that were attributed to a specific Medicare patient or a specific provider. If you don't have enough patients to meet one of those measures, then you only get scored on a single measure. Again, cost is just 10%, and this is kind of new. Right now, they are piloting, I think, 8 different episode-based cost measures, so they're going to get a little bit more specific with the types of patients they're looking at, maybe like a diabetic patient or a patient with heart disease, and trying to design some more specific cost measures around that. Your third category within MIPS is going to be your improvement activities. So CMS wants you to participate in different activities that help improve clinical practice. So this category is going to be 15% of your final score in 2018. All of the different activities that are listed are either attributed as a high weight or medium weight activity. The high weight are 20 points and the medium weight are 10. So if you get 40 points total, that is the maximum you can get for this category. Smaller rural practices, this is one of those exceptions that you get. Your activities count as basically double the points. So if you completed one high weight activity, that's going to give you 40 points, and that's going to satisfy that entire reporting category for you. If you look on the QPP website, there's 113 different activities to choose from. The example that I gave here is one that I recommend to a lot of people. Number one, because most people are doing it because it's already mandated by the state. But that's the consultation of the Prescription Drug Monitoring Program. So as long as you are registered with the Oklahoma Bureau of Narcotics, your providers have logins and they're checking that on patients regularly like they're supposed to, then that's going to meet the improvement activity. One thing I will mention with these activities is all of these activities are just a yes/no attestation. So whatever activity you choose to participate in, make sure you keep some type of documentation. So make sure you keep screenshots of a login page, or make sure that you keep information showing that you participated in a study. So participating in population health studies is another activity. But just making sure that you have some type of documentation showing that you were active and engaged in that activity throughout the calendar year. Improvement activities, this one again is only 90 days. So quality and cost were both all calendar year of 2018, but improvement activities is just a 90-day reporting period. The fourth and final performance category under the MIPS program is promoting interoperability. Last year, this category was called Advancing Care Information, and the year before that, it was known as the Meaningful Use Program. And so promoting interoperability is really looking at promoting patient engagement and then that electronic exchange of health information between different healthcare providers. So this again replaces the Medicare EHR incentive program. I will put the disclaimer out there that the Medicaid EHR incentive program is still going on. If you never participated in that, it's too late to start. But if you have providers who reported under the Medicaid program, they can continue to report and get incentive dollars through 2021. So that's something, it's all done through the OHCA site. So if you have providers that tested in the past, even if they skipped a couple of years of participation, they can still get on there and report and get incentives through that program as well. Unfortunately, those two programs are separate. So if you report MIPS, that doesn't automatically get pushed to the state or vice versa. So you will have to participate in those separately. So this just kind of shows you, we initially started out with meaningful use, which hopefully everybody here is familiar with. That went from 2011 through 2016. They additionally had it set up in a format where there would be 3 different stages of meaningful use. It would kind of get harder as you go. It would start with just EHR adoption and getting structured data in there. And then it would continue on to where you're exchanging data electronically with other entities. So that program went away when the new MACRA legislation came out, and last year was the first year under the MIPS program. So last year, they changed to MIPS, they changed the meaningful use type objective to what was called Advancing Care Information, or ACI. Well, then again, this year, they released a new Promoting Interoperability final rule that really addressed and changed a lot of things for hospital reporting, but what it did is go ahead and change the naming structure for this category, but all of the measures within it aren't going to change until 2019. So we'll talk about the 2019 measures there again at the end of the program and how they align with the hospital objectives. So there's 2 different measure sets for this category, and it's going to be based on what version of your EHR technology you're using. You can do the regular PI objectives and measures, or you can do the transition objectives and measures. There's 2 different versions of certification through the Office of the National Coordinator. One is 2014 certification, the other one is 2015. If you're using the 2014 version, then you have to do that transition measure set. If you're using 2015, you can do either or. So just because you're upgraded doesn't mean you have to do the harder objectives per se. You can still do the transition measures. And I will emphasize that next year, 2015 certification is required for promoting interoperability reporting. So if you're not already upgraded to that 2015 version, make sure that you kind of get some plans in place as soon as possible so that you can get upgraded and have at least a 90-day reporting period this year for both the clinician and hospital program. If you're unfamiliar with the Chapel website, this is a website hosted by the Office of the National Coordinator. It's basically just an ongoing list of all the certified products out there. But you can type in your EHR vendor's name and it'll tell you what measures they're certified for, what certification they've met, whether it's 2014 or 2015, and just a variety of things about those products. So you're promoting interoperability scoring. All of these different performance categories have their own scoring method. Like I mentioned, with quality, you had 6 measures that are worth up to 60 points total. Your improvement activities, you just have to get 40 points total. Well, promoting interoperability scoring for this year is a little bit more difficult because there's so many different factors. You have your base score, which is worth 50% of this performance category. Your performance score, which you can get up to an additional 90% in points, and then bonus points, you can get up to an additional 25% there. So there's 165 total points available for this category. and you're just trying to get 100. So your score is capped at 100. If you get more than that, you don't get anything extra. But it just gives you a variety of ways to get your score up that high. So the minimum requirements, what you're going to have to do for this category is meet the base score. The first thing is you have to use certified EHR technology. So if your EHR is not certified, you're automatically going to get a 0 for this category. You have to submit a performance period of at least 90 days for this category. When you get into report, there's going to be a couple of different attestation statements. It's preventing information blocking and ONC directly reviewing this EHR information, and so you have to click yes to those. You'll have to submit yes to completing a security risk analysis, and then you have to have at least a 1 numerator or an exclusion for all of the additional base score measures. So I'll go over what those base score measures are now. So your base score is all or none. You have to, again, either say yes to the measure or have at least 1 patient meet that measure to receive all of your base score points. Your base score is made up of 4 or 5 objectives depending on which measure set you're choosing. So the first one is your security risk analysis. You have to complete a review or risk analysis every year, not just in accordance with this program, but in accordance with the HIPAA guidelines through the Office of Civil Rights. And then you also have to address any security deficiencies you have and make updates. So I want to emphasize that a little bit and just let you know that just by completing your risk analysis, it's not enough. You need to make sure that you've addressed some of those problems and shown change. And that's going to be required if you do get audited. They'll want to see some updates and changes on that document. The second one is e-prescribing, so sending your prescriptions electronically. You just have to send at least 1 prescription electronically to meet the base score part of this measure. So hopefully, even those docs that are really hesitant to e-prescribing, surely you can get them at least 1 prescription sent during your reporting period. The next one is provide patient access. So this is your patient portal objective. This is strictly looking at giving them access. And so as long as you've given access to at least 1 patient during your reporting period, then you've met your base score requirements. The next one is send summary of care. So that's a transition of care measure. So for any outgoing referrals or transitions of care, you have to send that continuity of care document or CCD electronically to the receiving party. So as long as you send at least 1 of those electronically during your reporting period, you've met the base score. For that one and for e-prescribing, I will let you know that there are exclusions in place. So if you write fewer than 100 prescriptions or have 100 or fewer transitions of care during the reporting period, you can exclude that objective for this year. And then the last one is the request accept summary of care. So that's when you're on that receiving end of the transition of care. You get the document electronically. You have to incorporate that information into your system electronically. So that one again has the exclusion for this year as well, to where if you receive 100 or fewer transitions of care, then you can exclude that objective. So again, you have to meet all of these base score requirements. Just have to have at least a 1 numerator for all of them to get a score for this category. If you fail to meet one of those, you'll get a 0 for the whole category. If you meet all of them, you're already at 50 out of your 100 points, and then you'll work with the performance measures and bonus points to try to get additional points to get your score up to 100. This quickly, we don't have enough time today to go over all of these different performance measures, but these performance measures are the additional measures. A lot of them you're probably familiar with, again, from the Meaningful Use program. But these measures, your percentage on that report is going to translate to points. So say you're at 40% for your providing patient access, you're going to get 4 additional points towards your 100. And so these measures include sending the summary of care, requesting, accepting summary of care, and provide patient access. I'll just mention on those 3. Those 3 are both part of the base score and the performance score. So with those 3, as long as you have a 1 numerator, you've met the base score. Anything over that you get in the numerator is just going to be more points to get your score up. View, download, transmit, that's going to be kind of the second part of the patient portal. That's patients actually logging in and doing something with the information. Patient-specific education, secure messaging with patients, patient-generated health data, clinical information reconciliation. This one, if you're doing the transition measures, is called med reconciliation. So for the regular measures, they kind of tack on a few other things like your allergies and your problem list that you have to reconcile. And then the last one is public health reporting. So that's going to be connecting to the immunization registry in the state, cancer case registries in the state, and then any other kind of professional organizations that may have registries. I know the Optometry Association has the AOA more, but there's a bunch of different ones out there that if you are engaged with them in reporting data, then you can get additional points for those as well. For the public health reporting, only one measure is required for your performance score. So if you say, yes, we're connected to the immunization registry, you get 10 points. You'll get an additional 5 bonus points for every additional registry you do. So if you do one that's required, every additional one, you're going to get another 5 points for those. So that's all of the different performance categories. Again, you have, for MIPS, you have quality, cost, improvement activities, and you're promoting interoperability. So you can do all of these reporting categories. You can report them in different ways. Some of them you can get online and a test, just manually plug in your numbers or click yes, no. For those, you can do promoting interoperability or improvement activities. Those are the ones that you can manually test. Quality is the one category that's going to have to be submitted electronically. So you will have to upload what's called a QRDA3 file to the QPP. So you can't just get on and plug your numbers in. A lot of your EHR companies out there can report this information electronically for you. If you're connected to a QCDR or other qualified registry, you can do it that way as well. Or if your EHR system can just generate that QRDA for you, you can get online to the QPP and upload that file yourself and see that it was successfully submitted. So again, multiple ways to report data, but they're all reported through the QPP website. So this is what the QPP website looks like. I actually disregard the image on the left, the enterprise portal. That changed as of January 1st. That was the old way to do it. So there on the right side, that's the QPP portal. You're going to just type in your user ID and password. If you already had an old existing EIDM password, that will work there. If not, the way that they are managing this now is through HARP. That's the HCQIS Access Roles and Profile System. And so as of January 1st, this is where new users will go to register. If you're locked out of your account, maybe you had an old EIDM account and reported last year but can't find that information, you'll need to go to HARP and get everything unlocked. So this is where you can go and create an account, attach yourself to a clinic or to an organization and report for those providers. And then the last thing really quickly on the clinician side of things is the payment adjustments associated with MIPS. So everybody that is listed as a MIPS eligible professional has to participate in MIPS. If you don't participate, you're automatically going to get a negative payment adjustment that kicks in 2 years after the fact on your Medicare claims. And so last year, 2017 was the first year you could report under MIPS. Those payment adjustments won't kick in until 2019. So for the first year, you can get a positive or negative 4%. And then that goes up to plus or minus 9% over the next few years. I will say if anyone reported last year and is logged in and looked at the information on the QPP, you will notice that you maybe did not get your plus 4% for reporting and you did really well. Medicare actually calculated that information wrong for the first year. They assumed that there were going to be an equal number of people who reported to the MIPS program and an equal number who didn't report or who got penalized. They made it really easy. All you had to do was submit one improvement activity or one measure and one performance category and you didn't get penalized. And so 92 or 93% of physicians nationwide all reported last year. And so those incentives were not there like they expected. I don't think this year you'll quite get the positive 5%. Again, the program's pretty easy this year. You only have to get 15 total points across all the performance categories to not get penalized. But the better you do, the higher incentives you'll get. And so that's going to continue to change going forward. It's going to be harder and harder to meet the baseline participation, and then your incentives tied to that are going to increase over the years. And so again, just a reminder too, these payment adjustments don't kick in for 2 years after the fact. So 2019 is just now when you'll see those the penalties or the incentives coming across for your 2017 reporting period. And if you're familiar with the meaningful use, that was really just the bulk incentive payments for providers. This is going to be a lot different since it's just tied to that claims data. You're probably going to see small amounts coming through on your claims. And so it's different. It's not going to be that big bulk incentive payment that we saw under meaningful use. So that's all of the information for clinicians that they need to do this year. Again, I know that's a lot, and there's a lot more detail I can go into on all the performance categories, but just wanted to give you an overview of what you need to do there. And now we'll jump into the hospital EHR reporting for 2018. So for 2018, the Medicare EHR Incentive Program, who can participate? It includes eligible hospitals, critical access hospitals, and then dual eligible hospitals. Meaningful use is no more. So this promoting interoperability final rule that came out last year changed a lot of things. It's going to change a lot of the objectives for 2019. But the one thing that went ahead and got put into effect for 2018 was just the name change. So you're reporting to promoting interoperability, even though it's still the old meaningful use objectives for this year. So for your hospital reporting period, it can be any minimum or any continuous 90 days within the calendar year. The only thing is that it has to be continuous and it can't cross over calendar years. So it doesn't have to be fixed to a quarter, just any consecutive 90 days in there will work. Same thing here that we just talked about on the promoting interoperability side for providers. So there's going to be two different certification versions for the EHR, the 2014 and 2015. And you'll see how, just like with the promoting interoperability program, instead of transition measures and regular measures, this will pertain to modified stage 2 reporting or stage 3 reporting. Again, if you are upgraded to the 2015 edition, it doesn't mean you have to report on stage 3 objectives that have higher thresholds. You can still choose to do the modified stage 2 objectives. So modified stage 2, I think this is going to be what the majority of people attest to. Unlike the MIPS program that we just talked about, they don't have quite as much flexibility under the old kind of meaningful use style. So you're going to have to meet all of the objectives, and you're going to have to meet the performance threshold for each objective. So the first one is protect patient health information. That's completing that risk analysis and addressing those deficiencies like we discussed. Electronic prescribing for hospitals, the threshold's set at 10%. So that's going to be all of your discharge medications. So you're going to have to prescribe at least 10% of those during your 90-day reporting period. Health information exchange, you'll hear this one kind of interchangeable, called health information exchange or summary of care. Then again, this again is your transition of care measure where you're sending those referrals electronically. So step 1, generate that continuity of care document, and step 2, send it electronically to the receiving party. A lot of you are probably familiar with direct messaging. That's the way that this objective was initially set up, was everybody would have a direct address, we'd exchange the information electronically, all EHRs can do the direct thing. It didn't really work out that well. Some systems, direct messaging works well, some systems, there's other things that work better. So they kind of backed off the regulations on this health information exchange measure to say, as long as you generate the CCDA and submit it electronically and make sure that it's HIPAA compliant, that will work. So you can use direct messaging in your EHR. You could use encrypted email. You could use a health information service provider or health information exchange organization. There's a lot of different things that you can do to exchange that information electronically. The one thing you cannot use is faxing. Unfortunately, even though it's electronic and HIPAA compliant, they're trying to get away from faxing, and so that won't work. But any other electronic transfer will work. The problem that you might run into there is if you're connected to an HIE, you're not going to be able to get those numbers out of your EHR. So you will have to rely on whatever method you're using to be able to get your numerator to report for that objective. So that one kind of can be tricky if you're using things outside of your EHR. And if you ever have any questions about that, you can reach out to myself or anybody on our team at OFMQ, and we can kind of walk you through that. So the next one after HIE is the patient-specific education. So this is, you have to provide clinically relevant educational materials to patients. This can be based on a medication they're taking, a condition they have, any variety of things. And it doesn't have to come from the EHR. So the EHR just has to be used to identify what type of education they need, but then that education can come from a variety of sources. The next measure under modified stage 2 is your medication reconciliation. So for hospitals, this one again is the transition of care measure. Almost that comes in your doors is a transition of care patient. So it's really just best practice to make sure that you're doing a med rec on everybody that comes through. If you're noticing that your report has really low numbers there, but you know that you've done a lot of med recs, you'll want to make sure that you're marking those patients as a transition of care patient in your EHR, whether it's under their reason for visit or somewhere else in the chart. So if they're not getting marked as a transition of care patient, they're probably not going to count in that report. The next objective is patient electronic access. So this is really kind of your patient portal objectives. There's two different measures within this one. The first one is provide patient access. So that again is just you making that information available to the patient. That can be sending them a link to their email to get on the portal, or that could be handing them instructions on how to get on the portal and register. Any of those things will count as providing access. And so you have to do that for 50% of your patients during your reporting period. The next one is the flip side. That's that view, download, transmit. So that's patients actually getting on and using the patient portal. They backed off of this objective. It used to be 5 or 10%, and they bumped that down to just one patient. So as long as you had one patient get on to your patient portal and look at something during your reporting period, then you're going to get credit for that objective. And then the last one for modified stage 2 is that public health reporting. And so there's 4 different measure types available. There's immunization, reportable lab results, specialized registry reporting, and then there's the syndromic health data reporting. In Oklahoma, we don't accept syndromic surveillance data electronically, so that's not an option for you. So you have to report on 3 of those 4, so you're really just kind of stuck with 3 different measures here. I think I've got it here on the next slide. Yep. So the Oklahoma State Department of Health hosts a couple of different online registries. They host immunizations for both hospitals and clinicians. They have reportable lab results for hospitals, cancer case reporting for clinicians. And so if you haven't already, make sure you go and register with OSCH on their Meaningful Use website that's listed there. They are currently in a holding pattern. So you can register, but it may be weeks or months or years before they're reaching out to you to kind of get that process going. Just by signing onto their website and registering, that meets the objective. And so as long as you've gotten on and registered, you can say, yes, we're connected to these public health entities. And so really the only regulations after that is if the health department reaches out to you to start setting up that connection, that you respond to them within 60 days. So again, they're in a holding pattern now, so just make sure you get on, update your reporting period, and make sure everything looks good on that website. Some example of other specialized registries, since you do have to have 3 public health registries for 2018. The CDC has national healthcare surveys that you can look into. You can also, they specifically list the prescription drug monitoring program as another option for public health reporting. So just make sure and look into that. Make sure you have all your providers registered for it. If it lets you do a facility level registration, you can do that as well to make sure that that counts for your public health reporting. Quickly, we'll talk about stage 3. So I doubt there's a lot of people that report on the stage 3 objectives just because the thresholds are a little bit higher than they are for the modified stage 2. But the objectives really are pretty similar. So again, you have your protect patient health information. Your e-prescribing under the stage 3 requirements goes up to 25%. Your patient electronic access includes your portal and your patient education. The only difference here with the patient education for stage 3 is that it has to be electronic. So more or less, you have to push that information to the patient portal for that one to count. Then they combine some other objectives under coordination of care through patient engagement. So your view, download, transmit is still just one patient. But then secure messaging and the patient-generated health data is 5% if you want to do stage 3. And then health information exchange, so that is both sending and receiving that summary of care is going to be a 10% threshold. And then your clinical information reconciliation is going to be 50%. So that's, again, going to include your medications and then tack on your allergies and your problem list. And then your public health reporting is the same under stage 3. So hospitals are going to have a different place that they go report this information. It used to be done on the EHR incentive website. I'm not sure if they have completely closed that site out. Last year, you could still get on and view past meaningful use payment information. So you may be able to log in there and see some old payment info, but you can't get on there and report data anymore. So starting January of 2017, they moved everything over to the QualityNet secure portal for meaningful use and now promoting interoperability reporting. So I'm sure most of you, if you work in hospitals, are very familiar with QualityNet for better or for worse. But now all of this stuff is housed within QualityNet. They're really trying to get everything under the same umbrella so that you're not having to report to a bunch of different quality measures on different websites through different programs, and really just making sure it's kind of more of a one-stop shop. When you submit your meaningful use / promoting interoperability data for 2018, you will have to get on there and submit your ECQMs as well. You have 2 different options on QualityNet. You can go ahead and manually plug in your data there if you want, or if you report that information electronically, you can get dual credit for reporting under the hospital inpatient quality reporting program and for your promoting interoperability. So if you're already doing some electronic reporting there, you can get dual credit. So that's just something to kind of be aware of when it comes reporting time. They do have a very helpful user guide if you haven't been in QualityNet for a long time or since these program changes have happened. And so just make sure that you are getting in there and make sure you can get logged in now. Sometimes just getting registered and logged in can be the most difficult or longest lasting part. So just make sure you're getting an early start on that. And then payment adjustments, we discussed payment adjustments on the MIPS side. So that's going to be a plus or minus 5% this year, going up to plus or minus 9%. There are still payment adjustments that kick in for hospitals if you don't report on meaningful use or promoting interoperability. All that incentive money is gone, and so now you're really just reporting to avoid payment adjustments. These are some tip sheets on payment adjustments if you're just an eligible hospital or if you're critical access. So the eligible hospitals get a reduction to the IPPS standardized amount for that year, and then CAHs get a reduction to their percent of reasonable cost. And so that is all for reporting that you're doing now for your 2018 reporting period. Again, you have until the end of March to report all that data. So make sure that you're logging in, hopefully in January or February. Make sure your login information is all good and that you're getting that information submitted before the deadline. Now I'll quickly go over what the Promoting Interoperability program looks like for 2019. So this program is going to kind of combine the old meaningful use, then ACI, and now Promoting Interoperability stuff for clinicians, and the meaningful use stuff for hospitals. And so everybody's going to be reporting to the same objectives and measures beginning this year. So the big thing is that you, again, have to have that 2015 certification in place. So it's a requirement for not just hospitals, but clinicians as well. So everybody has to be on the 2015 version this year. For 2019 and 2020, you're just going to have a 90-day reporting period under this program. Again, the name change that has already happened, but now, again, is officially in place for 2019. And then you're going to have a new scoring methodology. So instead of the meaningful use type scoring where you have thresholds that you have to meet and you have to meet all of the objectives, you have a little bit more flexibility under here and can kind of be rewarded for doing good at other things, but then not being penalized as much for the things you're not doing as well in. And then there's a bunch of measures that are going to be added or removed for this. So it might get a little confusing because we just went over all of the performance score measures for clinicians and all of the meaningful use measures for hospitals. But a lot of that stuff that we went over, you're going to have to report for last year, but it's not going to be in place going forward. So for the new PI program, you have a smaller set of objectives. There's only 4 objectives. There's going to be a couple of different measures under each objective that you report on. What you're trying to do is get to a total score of 50 points. There's 100 points possible. If you get 50 points, that means you don't get penalized. So there's no real benefit of going over 50 points, maybe just a little peace of mind. But as long as you get to 50, you won't receive those payment adjustments that we just talked about. So your 4 objectives for promoting interoperability are e-prescribing, health information exchange, provider-to-patient exchange, and then public health and clinical data exchange. So this is just a quick snapshot of all of the measures that they are removing or doing away with. So your request to accept summary of care, clinical info reconciliation, patient-specific education, a lot of these things, some of them that have even been around since the beginning of meaningful use, are all being removed for 2019. There's some measures that are going to stick around with modifications. So like you're sending the summary of care, the provide patient access, and then your public health measures. And then this information just outlines what all of the different measures are underneath those objectives. So you have your 4 objectives, and then these are your measures. You have e-prescribing, and then 2 new measures, the query of the PMP, which we talked about using for an improvement activity or specialized registry this year under the MIPS or meaningful use program. And then another new one that's verify an opioid treatment agreement. So that's really targeted at helping to reduce the opioid outbreak that we have going on right now. Then you have, I haven't really found a way to shorten this objective yet, so we don't have an acronym, but support electronic referral loops by sending health information. So that's really your sending summary of care. And then same thing by receiving and incorporating health information. So that's kind of your accept request summary of care there. Provide patients access to their health information. So now for the patient portal, beginning in 2019 and moving forward, you'll only be required to provide access. you won't be held accountable for whether those patients get on and actually use any of those features available, but you still need to make it available to the patients. And then your public health measure reporting is still going to be around. So this is just a quick slide to show you just kind of a breakdown of the objectives, how many points each one are worth in 2019. So you can see your e-prescribing is going to be worth 10 points. And then those two new measures under the e-prescribing are both going to be 5 bonus points for 2019 reporting. Your health information exchange, there's 2 different measures. Your send and then your receive are both going to be 20 points apiece. Your highest weighted measure is going to be that patient portal. So that's a big one. So again, this is just you making that information available to them. So hopefully everyone can score really highly. And again, you only have to have 50 points to not get penalized. So if you're doing well at that patient portal, that could be the bulk of your points right there. And then the public health and clinical data exchange. For some reason, they made syndromic surveillance reporting the one required public health measure. Again, we don't accept it in Oklahoma, so you'll have to do 2 additional registries. So if you report to the immunization registry and you report lab reportables to the state, then, and again, make sure that you're signed up on their website electronically. But if you submit to those 2 programs, you'll meet the 2019 objectives for that measure. So again, I know that was a lot. We're covering a lot of different programs, what you have to do for 2019 and when you have to report that this year, and then what some of the changes are going to be in 2019 going forward. Does anybody have any quick, just kind of general questions, maybe not EHR specific, but any general questions about the programs or reporting?
This is Laura. I'm going to unmute all of the lines all at the same time. So yes, so everyone should be unmuted. Let me go through and make sure. So yeah, if you have a question, please just say it or feel free to type it in the chat box.
Yes, Jason, this is Cassidy at Fairview, and I got in on part of the registry information. Okay. I was wondering, is OSIS, the state immunization thing, does that count as the registry?
No, so OSIS is separate, and that's actually a question we get quite frequently. Kind of big picture, once they get their new system in place for the immunization registry, that system and OSIS will kind of merge to where you eventually aren't having to do that manual entry into OSIS anymore. The way that it will work once the immunization registry is up and running, they will more or less build an interface with your EHR so that you're constantly submitting that immunization data to the state. You'll actually get feedback reports for them as well. But once all that's up and running, again, it could be a year, it could be a few years, I don't really know. But that will kind of take the place of your OSIS reporting down the line.
Thank you.
We have this here to prove that we are, wanting to do this. I think we should be getting 5 points this year.
Okay, I'll let people think for just another minute. Just briefly, here at OFMQ, we are kind of in the weeds on this stuff all the time. I know there's some of you out there that are like, how am I supposed to wrap my head around all these different programs and when and where to report? If you have any questions about that, if you're needing help with any of those services, you can reach out to OFMQ and we can help you out with a lot of those things. And then this is my contact information. You can feel free to email me directly or call me. There's additional information on our website. And then we work with the Office of the Rural Health on a lot of different projects. We typically attend their conference, speak at their conference. And so if you get a hold of Laura, she always knows how to get a hold of us and get questions answered as well.
Jason, will we be sending out the presentation, a copy of your PowerPoint?
Yeah, I can send the slides over to you, Laura, afterwards. Or if you want to send me a registration list, I can send it out to everybody. Either way works.
Okay. So yes, Darcy, we will get the slides sent out. Are there any other questions? All right. Well, Jason, thank you so much for doing this. In comparison to our quality webinars, this has been the most attended webinar, so congratulations. But we really appreciate your help and always willing to answer questions. So if anyone thinks of a question afterwards, please let me know and I'll get in touch with Jason. And also, if if there's an issue or a concern or anything, please let us know. Odds are your peers have the same question or issue, and we'll be happy to look for speakers or reach out to our friends. So thank you guys, and everyone have a good day.
Thank you.